first National Institute of Peri. I have never met Dr. Peri personally before, but I used to give lectures about BTE in pediatric surgery, and I always was basing my introduction on the Cabrini score. So the name is very familiar, probably to everybody on us. Giving more details about the CV, Dr. Cabrini will undermine his achievements. So is he going to give to get to speak? Yeah, I'll give the floor to Dr. Cabrini.
Hello, everyone. It's a great pleasure for me to come to you today, albeit virtually, to discuss a very important topic regarding venous thrombosis prophylaxis. You notice the shirt I'm wearing says, "Never kill a friend, never treat a stranger." And that means when you meet somebody, you've got to make them like your friend by interrogating them. Of course, once you know about them, you would never hurt them or kill them. So you would never treat a stranger, and you would never kill a friend. I'm indebted to all of my Middle Eastern colleagues for the opportunity to present these data. Here are my disclosures. Now, more than 100 years ago, Rudolf Virchow described a triad of factors associated with the development of venous thrombosis: stasis or slowing of the blood, vessel wall injury, and hypercoagulability. Now, major surgery involves all of these factors. The effects of anesthesia, remember, anesthesia, even more than the surgical procedure itself, replicate Virchow's triad. There's venous stasis due to calf muscle paralysis. And when that happens, there's over-distension of the veins in the calf, producing endothelial cracks. Now, this over-distension was clearly shown by Philip Coleridge Smith in 1990 when he published a paper showing the duplex scan changes after an anesthetic with a muscle relaxant. And hypercoagulability occurs secondary to the surgical stress, the retained metabolites, the stasis in the leg, and whatever underlying pathology the patient may have: inflammatory bowel disease, infection, tumor, and so forth. The time of anesthesia intensifies these effects. That's why the use of pneumatic compression during surgery is critical to minimize these changes, but it doesn't make them go away. Here we see what happens to the veins when they overdistend. This is a 1,000,000 power micrograph of a capillary during an surgical experiment that's provided to us by a brilliant vascular surgeon and researcher, Tony Camerata. And here you can see that endothelial cracks form as the vein gets bigger and bigger. And as the cracks develop, then clots can form in those cracks. Finally, when the stasis occurs, as you see the darkening in this video, white cells change into adhesion molecules, and they land on the wall of the capillary, and they finally are rolling along and come to a stop. And then they extrude granules, which elicits an inflammatory response that destroys the wall of the capillary. It creates a hole in the wall of the capillary. Then other white cells change into adhesion molecules due to the stasis and come along and join in. And here is a picture in an actual of the actual experiment. You can see the stasis molecule here that comes when the white cell undergoes stasis. It's an adhesion molecule, and here it is penetrating the wall of the capillary. Now, another thing that we've known for quite some time is that most people get their blood clots when they come home from the hospital, and 3/4 of them, and then half of them get the clot after anticoagulants are stopped. This was shown by that brilliant investigator, Professor Juan Arcelas, who's a professor in Granada. What's really interesting is, and I remind all of you that sort of poo-poo the old literature, because some of the old literature was very well done. So Juan redid this data in non-cancer surgical patients in 2019. he showed the same results. And it's very important that high Caprini scores receive extended prophylaxis. And by the way, I'd like to mention that there are many roads to Rome. And other scores can be used depending on your locality, ability to collect data, and so forth. And so we have enough data. We've had it for many years to prevent blood clots. And we've also got the algorithms. The Caprini score is the most extensive algorithm, most frequently used in surgical patients. What are the barriers to prevention of fatal pulmonary emboli? Inadequate data collection, where all the questions aren't asked. And I'm going to show you later in the bariatric series, even in this Boston Center, the questions, some people didn't answer the questions properly, and that caused them to have a postoperative blood clot because they didn't get protected. And the other thing is failure to implement evidence-based care pathways. And just like the rider and this motorcycle are disconnected, so there's a disconnect between evidence and execution as it relates to VTE prevention. Reducing VTE deaths requires mandatory and consistent implementation of appropriate care pathways. Now, let's talk about the Boston Medical Center, which is the largest safety net hospital in New England, responsible for care of the indigents, as well as being a very famous university teaching and training center. And it's the major teaching hospital for Boston University School of Medicine. Now, they adopted a protocol which was mandatory. It was standardized. It was integrated into the EMR, and it was automated and easy to use. It was linked to the recommended prophylaxis according to this algorithm, and it was combined with early mobilization. Here is a picture of the actual screenshot in the electronic medical record of this program. And there's also lists here. There's factors that are associated with increased bleeding, and they're listed here. And then the doctor always had the ability to opt out if the doctor didn't feel it was right for the patient, but they did have to supply a reason. That was important. And so how does this work? Patients who were low risk and had scores of 0 to 4, you could do what you wanted in the hospital, and there was 100% compliance. Now, when the patients had a score of 5 to 8, they got 7 to 10 days of low molecular weight heparin prophylaxis. Didn't make any difference if they were in the hospital or not, because this is the period that's been shown in 160 trials around the world over 35 years, that the period of efficacy for prevention of venous thrombosis is 7 to 10 days. And for you skeptics that say, oh, that literature is old, remember that that was venographically based literature, the most solid literature we have. And there was 89% compliance with the 7 to 10 days. And then if your score was 9 and above, you got 30 days of prophylaxis. 3/4 of the people followed, where physicians followed that. Now you would say that, how did they do that? Because sometimes you have the donut hole and it's very expensive for low molecular weight heparin. They worked out a whole program so that every indigent patient, for example, that couldn't afford it, did get whatever they needed for prophylaxis. And look at what happened to their rate. Their rate fell for DVT rate 1.9 to 0.3%, and the PE rate fell to 0.5%. That's not all. This protocol has been in place for over a decade, and they've maintained a very low incidence of venous thrombosis throughout. There was a blip here when the electronic medical records were changed, but this has been consistently done over a decade, and they've now published 18 papers showing the efficacy of this approach in a wide variety of surgical patients. Now, turning to bariatric surgery, this is a study about sleeve gastrectomy. 638 patients with an average preoperative BMI of 44.4. 24% of the patients, excuse me, had Caprini scores that warranted extended prophylaxis following discharge, either 7 to 10 days or 30 days. The results using the Boston algorithm from 2000 to 2018 and evaluating the Caprini score, that's when this was published, showed that at the time of discharge, patients that had a high risk of VTE were discharged on extended courses of VTE. They also recorded if bleeding complications or VTE events occurred in the first 180 days. That's important after a laparoscopic sleeve gastrectomy. Patients received 5,000 units of unfractionated heparin or 7,500 units of unfractionated heparin. If the BMI was over 40, these doses were continued, started preoperatively and continued postoperatively, plus SCD devices. Low molecular weight heparin, 40 a day for those with a BMI of less than 40, or twice a day if the BMI was over 40, when the scores were 5 to 8, or 30 days when the scores were 9 and above. No patient discharged on extended VTE prophylaxis in accordance with the protocol developed a VTE event. Likewise, no patient deemed to be at low risk for VTE based on their accurate Caprini scores developed a VTE event, and no episode of the dreaded portal mesenteric venous thrombosis occurred in this series. 3 patients developed a postoperative VTE, but again, no patients with portal mesenteric venous thrombosis. These 3 patients were inadequately scored and as a result did not receive postoperative prophylaxis. A family history of thrombosis was elicited when these patients returned with their DVT. When they come back from the DVT, they were more thoroughly questioned and they admitted that there was a family history of thrombosis. No bleeding complications were observed among patients who received extended VTE prophylaxis. Now, here are the 3 patients. You can see their scores were 4, but their scores were really 7 because family history of thrombosis wasn't elicited. So therefore, they didn't get the prophylaxis when they went home, and as a result, they got a clot. So, in conclusion, the Caprini score set point for high and highest risk patients dictated the length of thrombosis prophylaxis in the Boston protocol. No DVT events were seen in patients with a Caprini score of less than 5. Bariatric patients with a BMI of greater than 40 received double the standard prophylactic dose of unfractionated heparin or low molecular weight heparin. The Boston algorithm, coupled with a mandatory prophylaxis policy, was very effective in preventing VTE, including the dreaded complication of portal mesenteric venous thrombosis. Failure to track obstetrical complications and/or family history of thrombosis may result in a serious VTE event or fatal outcome. And I'd like to emphasize that because no matter what risk assessment you're using, if you're not using the Caprini score, you must ask about obstetrical complications because people that have a previous history of obstetrical complications may carry an antiphospholipid antibody collection of genes. They can be beta-2 glycoprotein, anticardiolipin antibody, or lupus-like anticoagulant. And they can carry those genes in their blood long after their obstetrical career is finished. And if you don't ask these questions about what happened during their obstetrical career, then you can miss it, and it might result in a death or a serious clot in a patient that otherwise could be avoided if they got appropriate prophylaxis. Same thing with family of history. The only risk assessment in the world that counts family history of thrombosis is the Caprini score and the British score, which is a different score than the Caprini score, but a very good score. And what the British people did is they tied it to reimbursement. So if you had to follow the recommendations of the British score, then you got paid. Otherwise, you didn't get paid. And so it was very popular to follow the recommendations. And they estimated in 1 2-year period, they saved over 700 lives. Now, we need always to have further study to validate these results, no question about it. And especially, we're just scratching the surface in bariatric surgery. There's many, many issues, and a lot of them will be discussed during this symposium. So again, I'd like to thank you for your attention, and I'd encourage you, know your Caprini risk score for blood clots and save the patient's life. So you'd never want to meet someone without interrogating them fully. And once you interrogate them fully, they're not strangers anymore. So never treat a stranger, never kill a friend. Take your risk assessment. You can go to my website, Caprini Risk Factor score.org. And you can take your risk assessment. There's a patient-friendly version. You can ask a question, and you can go to the Resource Center, which has over 100 videos, which you can view, and all 320 or 30 articles on the Caprini score, either the abstracts or a full article, the complete PubMed listing, and it's updated every week. So thank you again. It's a great honor to be with all of you. I wish I could be there in person. I'd love coming there. And I'd also like to thank Aspen Healthcare for helping to facilitate this entire process. Thank you very much and have a great day.
Dr. Cabrini, do you hear us now?
Yes. Yes.
Okay. So now we'll go for discussion. 5 minutes. Prof. Walid, go ahead.
First of all, Dr. Cabrini would like thank you for this wonderful presentation. Do you hear me? Do you get me? Can you hear me?
Yes.
Can you hear me, Dr. Cabrini?
Yes.
Okay, I think there is a time lag when I'm talking till you reach it reaches you. So
No, I don't know why oh, now you should be able to hear me.
yeah, we can hear you very well, but we'd like to thank you for this very important clarifying talk. It emphasizes on something that we have been practicing and we've been preaching for the last, I would say, in my career, 12 years, and stressing the importance of take-home anti-thrombolytic medication injections and teaching the patient how to take it at home. Very, very important, especially post-bariatric surgery, post-sleep, post-bypass. And as you said, the European and the English and the American school have varied in the intensity of management, but they all agreed that it has to be implemented and it has to be followed. Now, the little thing that we disagree or agree might be how big the dose should be and how frequent. What does it depend on? Does it depend only on the BMI, or does it depend on the length of surgery, the difficulty, the complication in the surgical procedure itself, the need of ICU admission for 1 or 2 or 3 days even? So is there a table that can give us an idea how to follow depending on those?
Well, that's a very, very good question at the heart of the issue. And someday when we have artificial intelligence fully integrated, then we can look at the 60 or 70 variables that might bear on the situation. For now, I would suggest the following. The first thing is the score. And the score has to be done not only on admission, but it has to be done throughout the hospitalization and redone at discharge, because oftentimes there will be a change in the score based on things that happen during the hospitalization. Leaks, having to go back to ICU, a reoperation, an unsuspected diagnosis of cancer, the need for a central line for IV access, the development of a pneumonia or other serious infection. So all of these things, when added together, will give you a composite of what you need to do for the patient. And the patient, as we showed in this series, some of the patients were low risk, but it was left out, family history of thrombosis. And when you look at all the risk assessment tools, they all talk about thrombophilia. That's the wrong target, because most patients that get a DVT will have a negative thrombophilia marker because we don't have all those answers. But family history is important. Family history is important because of the fact that things run in families, cancer, heart disease, diabetes, obesity, and so forth. So the specific answer to your question is a dynamic assessment of the Caprini score. Then the dosage. Now there's a lot of controversy about the dosage. I would start by using the Boston system, dividing everybody into either above or below 40, a BMI of 40. And if the BMI is over 50, maybe you'll have to make an additional calculation. But we know there's pros and cons using the 10A assay to do this. But for now, I would start with the Boston protocol. Low molecular weight heparin, 40 milligrams once a day for a BMI of less than 40, twice a day for a BMI of over 40. Continued with a score of 5 to 8 for 10 days, and if the score is 9 and above, 30 days. Unfractionated heparin could be used, 5,000 units TID, for less than a BMI of 40, or 5,000 or 7,500 units TID for a BMI of over 40. Remember that the use of unfractionated heparin carries a 2.5% incidence of heparin-induced thrombocytopenia, and the low molecular weight heparin, 0.2%. Now, the other thing, and I'll stop here, but we also need to put into the equation a direct oral anticoagulant, because compliance may be a problem. People giving themselves 30 days of shots, but they'd be much more likely to take rivaroxaban once a day or apixaban twice a day for the 30 days. So that's part of the data that we need going forward.
Thank you very much. We can now take another question from the podium, please. Professor Wissam Jamal from King Abdulaziz University is going to ask a question.
Okay, thank you, Dr. Caprini. Just my question, maybe first to the audience and maybe Dr. Walid Bukhari, what's the best time for the peri-operative heparin that we give for the patient? Is just we give it at midnight for the surgery, just immediately in the holding area before going to the OR, since we just talk about the venous distension, venous stasis. So I think there is no one, just we are different. If we ask all of us, just we will find everyone has his own protocol. So I don't know, Dr. Walid, what do you think for just
So that's another very good question, which is unsettled. And I've always looked at giving the dose 12 hours ahead. To me, didn't make much sense. And as you know, in surgery, if you give the dose in the holding area, by the time you get down to the essential elements of the surgical procedure, if it's unfractionated heparin, it's pretty much worn off, 40-minute half-life. Think about 40 minutes into an operation that may last 2 hours or so. So that I don't think that I don't think there's a disadvantage to giving it in the holding area, and that's really what I would prefer. Now, all of that having been said, we have to understand that in various countries and in various guidelines in those countries, the recommendations are different. So if the official recommendation is for 12 hours preoperatively, then you probably should go with what the official recommendation is. As far as I'm concerned, that's my personal opinion about giving it. I like to give it in the holding area. And another thing I would point out to you that I was unusual. I don't know why I was so unusual, but as a surgeon, I also ran a blood clotting lab and took a blood clotting fellowship. And I would go to the operating room sometimes with my colleagues and have a heparin drip going throughout the procedure because they might be at very, very high risk. And I would say, well, I'm a surgeon. I'm going to look over your shoulder. If it looks to me like the heparin's causing bleeding, we'll stop it right away. But I'm amazed at how much you can give unfractionated heparin in a low dose throughout the operative procedure. So that's another little off-label secret that I've used. Let's say you have a patient that develops a blood clot, and in this case, it would be somebody probably that also had cancer, and you don't want to wait 6 weeks or 8 weeks. So anyway, in the final analysis, there's no one answer to the question.
In my practice, I would give the unfractionated heparin 40 minutes to 30 minutes prior to surgery. On table, actually, after anesthesia, we would give them a shot. When it comes to coagulation and thrombosis, you know, we worked in Pittsburgh in one of the largest centers for liver transplant with Professor Stalvin.
Right.
And you could see that the period between transplanting the liver and the ignition of the coagulation factors sometimes takes 10 minutes after finishing the vascular anastomosis. Sometimes it takes 3 hours. And in that time, you know, it's a major surgery with a lot of open wounds. We, as young surgeons, our job was to deal with those medium to minute bleedings to make sure that while the blood is going on, and vice versa, when the patient in full coagulation, full functionality of the liver, we have to quickly give the antithrombolytic medications and
Right.
monitor that. And that was 1993, 94, if I remember well enough, long time ago.
Well,
Thank
just
you.
to add to that, one of the things that I did, and I don't have any idea why I got involved in this, but I I developed a technique using the thromboelastograph with putting the blood in the cups within 4 minutes, and one of the best uses of that thromboelastograph was during the anahepatic phase of liver transplantation, when you didn't really know what was going on, and the TEG could give you a clue. And so that was a very important thing that we did for years. I think now the TEG is finally coming back. People are realizing how important it is to assess this during serious operative procedures like liver transplantation.
Thank you, Dr. Cabrini. Thank you, Dr. Cabrini. Too many good questions and points to be highlighted, but for the best interest of time, and to give a chance for other speakers to take on the subject from different angles, I'd like to introduce Dr. Awaid Al-Malki. He is one of our colleagues, consultant geriatrics, as the prosthetic surgeon. His talk is going to be about VTE after geriatric surgery and highlighting the current.
Dr. Cabrini is continuing with us. He will stay till the end of the club. So he will with us. He will hear the discussion and he will comment also.
Thank you. I'll be listening.
التوك حقنا اليوم زي ما هو العنوان عندنا حيكون عن الجايد لاينز والانسيدنس حق البروفيلاكسيس. حنتكلم عن الكونترافيرسي كلها اللي تكلموا فيها الشباب وقالوها وكان ديسكشن مع الدكتور It's my pleasure to introduce my R4, Dr. Khalid Mansouri, and he will start the presentation, and we try to summarize the updated and recent guidelines regarding the prophylactic VT.
Shabab, if you can post your presentation so also Dr. Cabrini can see it and also the other people online can see it.
Sure. Yes, we will do, Prof. We will share it now.
Because I guess your presentation is thromboembolic disease as well, is it? Your cases?
Yes, we have it now. Everybody is watching and you can
Yes.
see. Okay.
I guess we lost the voice, maybe?
No.
السلام عليكم.
Yeah. Now we hear it.
Good evening, everyone. First of all, I would like to introduce myself and Dr. Khalid Sorry. I am a general surgery resident at the Armed Forces Hospital. I'd like to thank the Saudi Society for metabolic and bariatric surgery and Dr. Oidan Malki for giving me this
Maybe we
opportunity.
can have the mic closer to the speaker so it will be easily heard on the online, please.
That's good.
Okay.
Right, our topic will be about the VD after bariatric surgery, with guidelines and recommendation. We're going to talk about 16 update statements that has been issued by the American Society for Metabolic and Bariatric Surgery in 2022. And we'll go through two interesting papers actually published. One is regarding the agents, duration, and the dosing of the anticoagulant, and the other one with new interesting way of how to calculate the dose for the low molecular weight heparin for each patient. So we'll start with the brief introduction that the incidence of the deep vein thrombosis and pulmonary embolism after bariatric surgery ranges from 3 to 2% respectively. And it causes significant increase in mortality rate from highest of 2% without complication up to 8.6% with these complications in patients. So most of these complications actually happens after discharge, reaching up to 83%, according to the American College of Surgeons. So this is the scope of my speech, the American Society for Metabolic and Bariatric Surgery update position statements on peri-operative venous thrombosis prophylaxis in bariatric surgery 2022. So it has 16 summary of the statements. We'll go through them briefly, inshallah. So the first statement is that post-operative venous thromboembolism, although it's not a common complication, but it causes significant mortality and morbidity for the bariatric surgery patient. And almost all bariatric surgery patients considered at least to be at moderate risk for venous thromboembolism even. And if we calculate the most high or low risk patient for bariatric surgery using Capillary score, it will score 3, and 3 will be considered as moderate risk, with some patients even having high risk and extremely high risk for venous thromboembolism. And also factors that places the patient into high-risk category has been suggested, including male sex, immobility, higher BMI, complexity of the surgery, and the duration of the surgery, especially more than 3 hours. And they suggested some surgeries are having high risk more than the others, like the duodenal switch, more than raw and wide, more than sleeve gastrectomy, and more than adjustable gastric banding. Also, hormonal therapy either being used as hormonal therapy post-menopause for contraception or even selective estrogen receptor modulators are considered risk factors for venous thromboembolism. And the discontinuation of these agents should be considered in the peri-operative period to minimize the risk of venous thromboembolism intra and post-operative. And also they recommended to adopt a good protocol for venous thromboembolism prevention in all bariatric patients, and that should include early ambulation and good hydration and mechanical thromboprophylaxis. After that, they suggested also with the mechanical thromboprophylaxis, we should integrate the pharmacological thromboprophylaxis. And for that should be continued throughout at least the hospital stay. Nowadays, we have hospital stay for 1 to 2 days. So for high-risk patients, also they recommended to continue for extended thromboprophylaxis. So overall, we have no high-quality evidence exists for choice, dosing, duration, or pharmacoprophylaxis after bariatric surgery, with even conflicting data in the literature regarding the pharmacoprophylaxis. So we have the systemic review and meta-analysis talking about the efficacy and safety of pharmacoprophylaxis for venous thromboembolism in patients undergoing bariatric surgery. It compared dosing, different agents, and different methods of thromboprophylaxis, even discussed the advantage of augmented versus the standard dose of the thromboprophylaxis. So first, they compared the low molecular weight versus the unfractionated heparin. 2 studies are there. Both of the studies suggested that there is no difference in prevention of the VTE. But in the bleeding, they have 2 results. The first result that the enoxaparin given BID can increase the risk of bleeding more than the unfractionated heparin. The other side suggests there is uncertain result for the thromboprophylaxis given in augmented dose with the low molecular weight heparin versus the unfractionated heparin. So we have low and very low quality of evidence, and this is the issue of our topic regarding thromboprophylaxis. Next, they consider the low molecular weight heparin versus the Peri-Operative. And there is one randomized controlled trial that compared the enoxaparin given twice than Peri-Operative given once. And the result was the same regarding the prevention of venous thromboembolism. In regard of the bleeding, there is no significant major bleeding require hospitalization or require admission to ICU or reoperation in both groups. But minor bleeding happened in some patients receiving enoxaparin twice. So regarding the augmented dose versus the standard dose, with the standard dose being defined in this study as enoxaparin given 40, 60, and 80 milligram once daily, and 30 milligram given twice. And the augmented dose in those higher than that. They found out in 7 studies, 5 of which are observational studies and 2 randomized controlled trials, that the venous thromboembolism did not happen in each group for the randomized controlled trial and for the observational studies. In the next slide, we have the risk of bleeding, and they suggested that patients receiving augmented dose may have a higher risk of major bleeding than the patient receiving standard dose of low molecular weight heparin. Now, the last comparison is the duration. The duration is restricted versus extended, with the restricted being defined as receiving pharmacoprophylaxis during the hospital stay only, and the extended prophylaxis defined as receiving thromboprophylaxis during the hospital stay and after discharge for 7 or more days. And they found out in 5 observational studies that uncertain effect of the thromboprophylaxis in the extended. But in the next study, they have pulmonary embolism happened in 2.3%, where in none happened in the control group. So they prefer to give the patient the restricted prophylaxis. In the next study, they reported 4 cases happened with portum-centric venous thrombosis, where no cases happened in extended thromboprophylaxis group. So they in favor of extended thromboprophylaxis. In regard of the bleeding, they suggested that the extended thromboprophylaxis might increase the risk of bleeding in those patients. So for the 13th statement, for VTE prophylaxis patients with severe renal insufficiency, there is several dosage regimen has been suggested in this study, including reduction of the dose of the low molecular weight heparin, giving the minimum dose as minimum as 30 once daily, dose adjustment based on the anti-factor 10 level, and the use of unfractionated heparin, and administration of low molecular weight heparin, fixed dose, BMI or weight titrated dosing, or dose adjustment based on the factor 10 level has been suggested in this study. For the next slide, we have this study, and interestingly, they include also the estimated blood volume. So in the next slide, we will see that the heparin are large weight molecule, and it tends to be kept intravascular. So a recent study in trauma-surgery population, they have demonstrated that patient estimated blood volume correlates better with the anti-factor 10 level than BMI. And that's because when we calculate the BMI, we measure the height in function of square. And in the estimated blood volume, we mentioned that the patient height will be EQ, and we pay regard to the patient sex, either male or female. And it is worth mentioning that most of the bariatric surgery patients are female, and females per se have lower height than men. So the primary objective was to evaluate the effectiveness of BMI-based prophylactic enoxaparin dosing at achieving target anti-factor 10 levels. For the next slide, we will see how does that happen. So the anti-factor 10 level attained with BMI based dosing in 84.7% of the patients. 10.2% of the patients received higher dose than required, and 5.1% only received a lower dose. And patients above the target of the factor 10 level with 7.3 centimeters shorter than those within the target level. Two of those patients developed bleeding post-operatively. One patient had bleeding from the short gastric artery, required 4 backed RBCs transfusion and reoperation. The other patient developed hematemesis and melena, which was self-limited, and the patient resumed anticoagulant once that issue resolved. So, theoretical estimated blood volume guidelines was developed. So, if you follow that estimated blood volume guidelines and we compare it to the patient who received BMI dosing, we find that 82% would receive the same dosage and 15% would receive lower dosage. That means 15% of the patients received unnecessarily higher dosage of the enoxaparin, measuring the anti-factor 10 level. For the 15th statement, due to the paucity of high-level literature guide to exact dosing of the low molecular weight heparin, anti-factor 10 must be used to monitor and adjust the dosing of low molecular weight heparin. And that should be specifically used in higher BMI patients because they have high estimated blood volume. So the last statement regarding the use of the inferior vena cava filter, they are against the use of inferior vena cava filter pre-operatively for all patients, and the risk assessment should be done appropriately before doing that, and we should weigh the risk and benefit for each patient we will consider for the IBC. So at the end, they stated that we should follow these guidelines with caution, and we should individualize our choice for anticoagulation for each patient, considering all circumstances, because we have only low and very low quality of evidence regarding the use of anticoagulation, regarding dosing, duration, and the choice of the agent. This is the end of my presentation. Thank you for listening.
Thank you, Dr. Khalid, Dr. Oil, for the excellent extensive review, discussion. And I have question for Dr. Khalid, Dr. Jabir, and Dr. Kabir. And now there is a lot of talk about anti-factor regarding the proper dosing of anticoagulant or low molecular weight. So where do we stand regarding cost effectiveness, availability, and
you have talked about something that we have not yet applied. We use it in very special cases where you have serious definite polyneuropathies. And these preparation availability plays a role. I cannot say much about the minimal experience.
We don't have anti-factor 10 to start with. I think it is
level, the anti-factor 10 level?
Yes.
Yeah.
But in my hospital, for example, we faced a situation with a new problem, probably not part of the scope of this meeting, is how to treat patients with new oral anticoagulants. Right? And this is an emerging problem because we see lots of patients now are on these type of medication, and we don't know if we do bypass what will be the right dose. And one of the solutions is to do an anti-factor 10, and we don't have this anti-factor 10. It is not something that is available probably, and I'm working in a well-funded hospital, and we don't have it. So I assume probably the majority of the hospitals here, if any, wouldn't have this. And if it is available, this would be probably restricted to special situations. My point is, sometimes you do not have to create a problem to find a solution. If you've been managing well all these patients with other tools, subjecting them to more extensive protocols like measuring anti-factor 10 is kind of very unpractical and very theoretical. Maybe good for research purposes, but not for individual or for practical daily use.
Dr. Cabrini, you hear us?
Yes, thank you very much.
Go ahead, Dr. Cabrini.
Yes, thank you very much. First of all, it's a very nice very nice presentation regarding the guidelines. And what's the trouble with the guidelines is that they put all the patients in the same basket without individual specific risk assessment of every single patient. You don't really get an idea, and that's one of the reasons why we're not getting any answers. And my plea to the audience is to individually risk assess the patients in a dynamic fashion, the way I talked about. And over time, I think we'll begin to clear up some of these issues. And again, you always have to remember, and I always tell people, sometimes they'll come up to me and say, well, I didn't give prophylaxis because the Caprini score was 7. And I said to them, well, did you take a look at the patient? The patient has sometimes has additional factors. For example, sickle cell disease, AIDS, blood transfusions, other factors. So you don't treat a patient with a score. You treat the patient on the basis of your overall judgment. You take a look at the guidelines, you take a look at additional literature, and you put the whole thing together. That's what's called clinical judgment and experience. And those of you that have been practicing for a long time know that you've gained a lot of experience, but you also have a lot of scars, because a lot of times what you tried to do didn't work out. So you had to try something different in order to get a better outcome. Thank you.
Thank you, Dr. Kapil. We'll move to next, and we'll leave the question after the next session will be 3 lectures.
Okay, now we move to the second part of the second session of this meeting. Is the session of hospital protocol for venous thromboembolism prevention. We'll start by Dr. Al-Wahash Khogir, and he's a consultant bariatric minimally invasive surgeon and King Abdullah Medical City in Mecca, and he will talk to us about the protocol there at this hospital.
Good evening, ladies and gentlemen. It's a pleasure to be here. My name is Al-Wahash Khogir. I'm a consultant bariatric surgeon. It's an honor to be here. I'll be presenting the hospital protocols for VTE prophylaxis in our center, King Abdullah Medical City in Mecca. So a quick overview about our center. We are a level A bariatric center accredited by MOH. We run a current caseload of 450 cases, bariatric cases a year. We've performed almost 4,000 cases up to now. We have a very good compliance in terms of patients follow-up. So the acute follow-up 3 months down is almost 95%, which I think is sufficient to detect any VTE events. Of course, this number has been severely affected during COVID times. So our protocol, we have published our protocols in terms of bariatric practice, including the VTE prophylaxis. It's available for all our staff. They can access it at any time. We have adapted those protocols in reference to ASN guideline and the NIH guidelines for thromboembolism prophylaxis. So we divide our protocol into pre-operative, peri-operative, and post-operative periods. In the pre-operative period, we aim only for risk stratification. We try to detect the patients who have high risk, patients with previous VTEs, hematological diseases, patients on chronic anticoagulants. And according to those high-risk patients, they should get an MDT approach, discussing this case with the involved specialty, and they have an individualized plan. Standard patients, they get a standard protocol. We have a very strict smoking cessation policy. Patients should stop smoking 4 weeks before and 4 weeks after preventing their VTEs. When moving to the pre-operative period, we operate on a same-day admission basis. So patients get admitted on the same day. Capillary score is applied on admission during surgery, during when the patient is on the table, elastic stocking and mechanical compression devices are applied, and they are functioning throughout the surgery. We start our chemical prophylaxis on induction. So on induction of anesthesia, we use unfractionated heparin, a dose of 5,000 international units once. That's at the beginning of induction. And for high-risk patients or patients with high BMI, we tend to give a higher dose of 7,500 international units. We apply ERAS protocol, so all our patients are early mobilized after surgery to prevent VTEs. Elastic stocking and compression devices are applied throughout overnight. We do not start our second dose of heparin until the next morning after we check the hemoglobin level, making sure there is no drop in hemoglobin. This has been our protocol. Most of our patients are being discharged on day one post-operatively. So in the post, what? So in post on discharge, standard risk patients get a standard dose of 40 milligrams of low molecular weight heparin once a day for 2 weeks duration. For higher risk patients or for patients with supermorbid obesity, we tend to give a higher dose, 60 milligrams low molecular weight heparin twice a day for 3 weeks duration. All our patients gets a 2 weeks follow-up to make sure they are quite compliant on taking the injections and they did not have any bleeding. So the question is, we didn't change our protocol since 2017. Is it effective or not? So according to our series, we have less than 1% incidence of VTEs post-bariatric surgery. We have a total of 8 cases, 2 DVTs, 2 PEs, 4 thromboembolism, portal vein thrombosis. Fortunately, we have no mortalities. Well, on the other hand, does our protocol increase the risk of bleeding? Again, we have a low number, less than 1%. So major bleeding, which we define as bleeding that requires blood transfusion, reoperation, or any intervention. We have only 9 cases, only 2 of those require reoperation, and fortunately, again, we have no mortalities. It's beside the point, but it's worth mentioning that in terms for bleeding, we can justify our low number that we tend to use reinforcements. So we do ulcering, we do buttressing, we use reinforcing materials, synthetic agents that could lead to these low numbers. So this is our protocol, and this is our team of success. Thank you for listening. And Dr. Caprini, if you're there, we would like to cordially invite you to our upcoming SASMBS annual international conference meeting. It's going to be in the lovely city of Jeddah. Hope it's going to be a great meeting. Thank you very much.
Okay, I think we move to the second speaker, then we'll formulate all the questions. The second speaker will be Dr. Shakir Majlishi. He will talk to, he's a consultant bariatric surgeon at King Fahd Hospital in Jeddah. He will talk to us about the protocol in his hospital.
Good evening, everybody. Thank you too much for giving me this opportunity to speak about our protocol in King Fahd Hospital, Prince Sultan Abdulaziz Center for Obesity and Advanced Laparoscopic Surgery. One of the, I think, is the first center of the kingdom specialized in bariatric and advanced laparoscopic surgery. Dr. Walid, we have the honor, is the founder of this center.
المرة دي يفتح
أرسلته على الإيميل صح؟ نعم، مو متعرف عليه، إيش الكمبيوتر ولا إيش اللي طالع؟ أرجع أرسل لي إياه تاني. إيش الوقت؟ مشكلة الكمبيوتر واحد فجأة لو في الأخير ما أقدر أقدم. اتصلت واتساب. Okay, I apologize for this technical issue. So I'll start with my presentation. We are now no different than the others. In our center in Bin Sultan, Cancer and Capacity Center, we have a high volume of patients. We do around 550 to 600 patients divided between elective surgery, bariatric surgery, and redo surgery. So our protocol is we are following the Caprini scoring system. So as mentioned before, I will not go through it again. The bariatric obese patient is a high risk patient. By definition, the minimum is a moderate risk for VTE. Okay, next please. So we are following, as I mentioned, the Cabrini scoring system. This is our protocol in the hospital. It was like a paperwork for the scoring for the assessment of all patients, admitted patients, especially surgical patients. They admitted for a bariatric. We mentioned as my colleague they mentioned the risk for VTE, the risk for high BMI, and for the other risk factor like blood disorder, smoking, hormonal therapy. Okay, next please. Next. Okay, so this is the sheet for assessment. This sheet was limited for all the patients that they admitted, and we converted to our Oasis Plus system. So this is the Cabrini scoring system. We divided the patient according to the age, the type of surgery, the BMI, the duration of surgery, the other risk factor as mentioned before. So accordingly, it's give the recommendation for the dose, the prophylactic dose, and the risk of bleeding for each patient. So as mentioned by my colleague, we are on the same page, Peri-Operative assessment, starting from the clinic when we saw the patients. We give the advice for stop smoking at least 6 weeks before the surgery, and a history of hormonal therapy or contraceptive should be stopped before the surgery. And if the patient is high risk or have any medical problem or hematological disease, it should be referred for multidisciplinary system, hematology referral, or vascular have any risk for previous thrombosis, previous PE. During the hospitalization, we admit the patient the night before the surgery. We give the patient 2 hours pre-op enoxaparin 40 milligram, 2 hours before induction. On call to us, we have time before starting the anesthesia. It's about 2 hours. And usually our patient, they spend like 1 hour in sleep and around less than 3 hours in bypass, sometimes more. So accordingly, we give the patient like 12-hour post-op, the second dose of enoxaparin. During the surgery, we apply the mechanical prevention also. We apply the pneumatic compression device. And post-op is we following the same policy. The patient is morbidly obese, BMI more than 40. We're giving the BMI-based doses of lumefantrine, enoxaparin, 40 for 2 times per day. And if the patient with a higher BMI, more than 50, we give the 60 enoxaparin twice per day. We give this protocol for 1 month. So we are following the same as mentioned. We don't have, as Dr. Tariq mentioned, we don't have the anti-vaccine level, unfortunately. So we are following what is available, what is useful in our hospital. So these are our reference. Thank you so much.
And now, Dr. Muhammad Hussein, Assistant Professor, Consultant Peri-Operative and Minimally Invasive Surgeon from King Abdulaziz Hospital. He will talk to us about the protocol of King Abdulaziz University Hospital, VTE prevention.
السلام عليكم ورحمة الله وبركاته. مساء الخير جميعا. Thank you, Dr. Hassan and Dr. Ali for this organization. So, I'm going to speak in 7 minutes around the VTE prophylaxis at King Abdulaziz University. So, till the end of 2022, we are using Venous VTE risk assessment electronic form, which was integrated in our electronic health record system, which is mandatory on that patient. So, we have to choose this patient either medical, surgical, or antenatal. Then the second part, we have to fill the Cambrian score version 2005 by this question, yes or no. And if it's high, if it's low risk, then the flag will be in green and marked as low risk. Then if the patient is high risk, Cambrian score more than 3 or 4, then change to red flag and asking the physician to choose either heparin, enoxaparin, or Contaminix with the dose, and this screen will appear on every page in the file of the patient. And if there is any contraindication for the pharmacological treatment, then the physician should click here contraindication and should notice why it's contraindicated, and again it will be appear in red in the file of the patient. But since January 2023, then we changed our electronic health system, so we lost our electronic form, and now we are using this paper VTE assessment test, which includes 5 parts. This is the first part, which is the identification of the patient, which should be filled mandatory at the admission time. And if it's not done, then the nurses will never accept any orders, and the system as well will not accept any order for this patient. And we adapt at the discharge our Cambrian score, because in our paper, again, we are using Cambrian score version 2005. So special attention at the discharge for any complications that happen for the patient during admission, or if he is a smoker or traveling, then they will be a candidate for extended thromboprophylaxis. The second part of our forms is the risk factors. So it's exactly Cambrian 2005, 0.1 for the age between 60 and 40 and 60. Then mainly the medical disease, cardiac, respiratory, or sepsis. 2 points for the 1860 and 75, and minor surgery of arthroscopic orthopedic surgery or laparoscopic maybe more than 45 minutes. Then 3 points for the age more than 75 or family history or coagulopathy, familiar as lupus anticoagulation or anti-cardiolipin. Then 5 points for heavy orthopedic surgery as the hip, pelvis, and acute spinal injury or multiple trauma. Then we calculate the total risk of Cabrini. The third part of our form, including the contraindication, which is mainly active bleeding, uncontrolled hypertension, epidural anesthesia, or intraocular intraperitoneal surgery, then significant thrombocytopenia less than 100,000. And a big portion with the history of the GI bleeding and coagulopathy. Here is noted renal failure with creatinine clearance less than 30, but it's not any more precaution and the prophylaxis dose of anticoagulation. Also, we should notice here the contraindication of the SCD, which include gangrene, recent drug, or suspected already DVT. Fourth part of our form is the recommendation. So it's classify the patient to 4 classes: low risk, the score 1 or less; moderate risk for score 2; and high risk for score 3 and 4; and highest risk for 5 or more. So for low risk, only early ambulation. For moderate risk, either pharmacological treatment or mechanical SCDs. For the high risk, it's a pharmacological treatment plus or minus the mechanical. And for the highest risk is both pharmacological plus the SCDs. The fifth part of our form include the follow-up of the patient. Just a reminder for the admitting physician that we have to start by a CBC and to repeat the CBC every 72 hours. And should notify the physician if the platelet drops less than 100,000. Now we are working on our electronic VTE assessment risk, but this time we are including Cabrini 2013, based on this paper published from Boston Medical City, which summarized the evolution of the Cabrini score. And the main difference, just extra point, including extra point for BMI more than 40 and the major surgery of more than 2 hours, 3 points, and considering here the smoking, insulin-dependent diabetes. And also for the recommendation, we are considering for the new electronic form to adopt the definition or the classification done by the University of Michigan, which classified the patient into 5 groups instead of 4 groups by adding the super high risk Cabrini score of 8 or more, because they have a risk of almost 10 to 11% of VTE post-surgery. For our pediatric patients, we classify in BMI less than 40, then BMI between 40 and 50, and above 50. So for the BMI less than 40, we give usually pre-operative the day before the surgery, Enoxaparin 40. If the patient not admitted the day before, then intraoperative on table after the induction, heparin of 5,000 international unit. But some patients, some surgeons now, they stop doing the heparin on table for the BMI less than 40, because then we notice there is increase in the hematoma and gastric bleeding, especially after the sleep restriction. And post-op for Enoxaparin 40 OD for 2 weeks for the low-risk Cabrini and 4 weeks for the high-risk Cabrini. For the BMI between 40 and 50, we give again the same thing, Enoxaparin 40 for table, the heparin 5,000, but the only difference is that the post-op Enoxaparin will be 40 BID or 60 OD, again the same thing for 2 or 5 weeks on Cabrini score. For BMI more than 50, we give Enoxaparin 40, but for the patient BMI more than 50 and the weight more than 150 kilograms, then we give Enoxaparin the day before of 60, and on table 5,000, and some surgeons go for 7,500 if again the weight is more than 150 kilograms. And post-operative will be Enoxaparin 60 BID, but here the minimum is 3 weeks, not 2 weeks, up to 4 weeks. And recently with our hematologist, they asked to extend till 35 days or 5 weeks post-surgery, mainly depending on this article from Cleveland, which showed the risk of the DVT here at 1 week, 2 weeks, and 3 weeks almost the same, decreasing the risk after 3 weeks, and still there is a risk of DVT at day 30. So they asked for extension till 35 days or 5 weeks after surgery. And as we notice here, BMI more than 50 is having double the risk of PTE post surgery. That's the for Singapore University.
Thank you, Dr. Lam. Now we'll go to our chairperson for the discussion. So this is the idea of this meeting. We have discussed the protocol. We are not taking the three high-quality governmental to see how we are diversing in the anticoagulation. But it seems there are not much differences. Hopefully.
Yeah, I think we have agreed in the previous meeting more than 4 years ago, if I remember well, that this is the one we're following. We're following Caprini's courses, finding what sort of therapy, and we have agreed, especially for morbid obese and super morbid obese, to give what I call it anticoagulants for at least 3 weeks, about 40. And some people at that time were discussing 6 weeks and 7 weeks and so on. Now it's a more definite picture we have. And I agree. Almost we are all doing the same, and we're coming out with a much better outcome. Previously you could hear somebody after surgery 2-3 days, he dropped dead coming to the hospital or complaining of chest problem or at home. And the first diagnosis comes in mind is pulmonary, but massive pulmonary. We don't hear this anymore, thank God, and thank God to Professor Caprini and the different application of these anticoagulants. Anyway, now we will start by just a second.
Yeah, just before the going to the question, I just wanna mention a few things on the analysis of different right now, and maybe this also will create just sharing thoughts with you. And I'm writing notes on the different protocols. I need also to get consensus and answers. And we'll start with the. I'm not criticizing. I'm just trying to elaborate and to get some answers for the smoking cessation. At least two of the speakers said we had strict rules about 4 weeks smoking cessation, and I don't know what is this. And how do you measure your patient's confidence to smoking? You just take his word. We have different ways to do this because we had this very strict rule in National Guard, and I'm not sure it worked very well. And I want to see if you have a better solution for that. For the end point of bleeding, for the presentation of the King Abdullah in Mecca, you mentioned your endpoint is transfusion and reoperation. Yes, it was this way for us, but at the end of the day, later on, we stopped in a way taking too many patients for reoperations. We had more conservative approach. So delayed on this, more hospital stay should be added as an endpoint. Sometimes you don't operate in the patient, but you keep him 2 days because so you probably would like to add this to your endpoints. Again, other endpoints we had when we designed our protocol that I'm not here to share because I'm not the speaker on this, is there are minor things like spotting excessive menorrhagia. This is a bleeding problem that mandates adjusting dose or do some reactions to it. The 2 hours pre-op, I am not sure I'm happy with. We give patients, and this is not different from any other surgery. This is, for us, it's a standard surgical protocol. We give the heparin in the OR. Sometimes you give the heparin and your patient is delayed for 6 hours, then you don't know what to do. And this probably is answered by the presentation of Dr. Winay. He says some of the patients, some of the doctors noticed increase in the ultra-operative bleeding. Probably this is also related to the timing of the pre-op anticoagulation. As a standard teaching, we give the prophylaxis before induction, shortly before surgery, not giving it much longer, including the overnight doses that we don't do for several reasons. One of them that because the patient they don't get admitted anyway, we don't have patient admitted. The mechanical and mechanical and chemical anticoagulation, we do it. We do above knee. Having said that, there is no data to show that it is of any value. Yeah, to add mechanical plus chemical, and this is based on the repeated guidelines that we were following. It's the American College of Chest Physicians that was handed to the American College of Hematologists later on, but the data never supported that going above knee, below knee, or giving mechanical with chemical is of an added value. There are a few points. I just wanted to highlight these points, and I'm not going to take the whole discussion, but these points were worth mentioning for me because I am not supposed to take the protocols as a standard. Obviously, we don't know exactly what is right and wrong, and this is what happened with us in the National Guard. We started with something that we change. Our endpoint at the beginning was not to see a VTE problem. Then we find that we have another factor in the equation, which is the bleeding. Then the patient complains. So if you can give patients, and duration we give 4 weeks, I think 4 weeks. This is based on the physiological studies that show that the VTE risk start dropping at 4 weeks. So this is where we stop. We don't stop at 2 weeks. The other thing with the King Abdulaziz University, I just have a comment. It seems there is a lot of variability, and this is not based on patient data, based on surgeon preference, which is making it very difficult for you at the end to analyze your results. Because basically, if you have all your protocols are changed on the surgeon's preference, then you don't have a protocol. There is something you need to look at to see at the end of the day what works and what does not work. Okay. Now I
have a comment on his school. What do you mean by mechanical?
The sequential devices, I give you an experience. I went to a private hospital to work and then requested a sequential device, and the medical director said, yes, I'll get to whatever you want if you show me the data that showed that this is superior to what we have. And I was so adamant and confident that this is the case. I searched the literature, though it makes sense, though I'm using it, though I'm still using it, but there is no evidence-based, there's no evidence-based medicine data supporting that adding the mechanical anti-embolic to the chemical device is changing the risk. Probably all of us using it. I'm saying that this is something we do, but that is not really data supported. Again, doing above knee, which I do above knee in my hospital, I use above knee, or going below knee, or going foot, did not show when you use the mechanical devices alone that one of them is actually superior to the other.
I understand from that, for the sake of any private hospital, conservation of economic and logistics, we should not use sequential.
No, I did not say this, and I don't know, this wasn't the conclusion you should reach. I'm saying I'm using it, and like many things we do, like we're giving 4 weeks or 2 weeks. What we do, because it gives us confidence, not necessarily as evidence-based. I'm saying you really have to use a prophylactic, VTE prophylaxis. We all probably are using for different reasons the chemical prophylaxis, and we're adding the mechanical. This is a side point that giving a mechanical prophylaxis is not necessarily is going to change the outcome. Having said that, I'm not saying do not use it or use it because I'm personally using it. This has nothing to do with the cost. Just I'm saying point, that scientific point that.
Now, we progress to
لا احنا في question smoke cessation. How would you think?
Yeah,
This is
usually you ask the patient to stop 3 weeks before surgery. And we ask them really at the time of the admission, we will ask them only by question. If he will not stop smoking, don't tell us because we will cancel the operation.
So you're taking his word, and you
Exactly.
don't have more.
And usually they are saying after surgery that they can't stop smoking and they are still smoking. And we adapt our PPE prophylaxis based on that.
I just want to know if there's a more,
There is no way.
there are ways to measure, but they're not.
Smokers, better not to ask them to stop. They will not stop. So just be clear with them and be frank. Ask them, just ask them to decrease. If they're smoking one packet per day, just come down to 10 cigarettes, come down with the procedure, not to stop. They will not stop. So just, even if they said, even this sweat.
If they don't
will
stop,
not
the doctor is coming. Do you change your mind from bypass to sleep, for example, or you make bypass a big no?
Yeah, if they are heavy smokers, yes, I will not go for bypass. If they are heavy smokers, it's not any smoker that I will not go for bypass. Heavy smokers, and I will concern them about the marginal ulcers. Smoking is not good even with sleep, we know that. So just it's more risky with the bypass, so heavy smokers, no. Or what I ask them, 1 month after the procedure, not to smoke a single cigarette. So sometimes before I take 1 cigarette, no doctor will tell you go and smoke a cigarette. Just go behind the door, smoke it, don't tell anyone.
You do bypass for smoker?
Heavy smokers, no. Smokers, it depends.
Big no.
How happy is happy?
I just, Dr. Kabir is giving an answer, he has a comment and we'll come back for this, for your question on. So Dr. Cabrini, you heard the different hospital, governmental hospital protocol, high polling protocol. You have to listen to Prof. Bukhari and Dr. Jaber, the chair, and Dr. Wissam comment. So what's your comment, Dr. Cabrini?
Well, I think that they're very, very well done protocols. I think that understanding now that it's important to start using the set score of higher than 5. The threshold for your patients has to be determined, and that's something that you need to do going forward, because not everybody over 5 is in the same category. There's an article in the Annals of Surgery that just came out in 4,200,000 patients, showing how the thresholds are different for different populations. And I think that your investigators should get together and take a look at the 90-day incidence of VTE in your patients and what the scores were in those patients individually. So then you can determine if your set point, for example, in Boston's experience, if the set point was, if the Caprini score was 5 to 8, they only gave 10 days of prophylaxis. But it was at 9 and above, they gave 30 days of prophylaxis. What would your data show? That's my first question. And I think what you're doing now is fine, depending on what your 90-day results are. But the other thing that I think is important, and I didn't understand everything that was being said about the mechanical devices, but
yeah,
it's very.
Dr. Tariq Jaber is mentioning that he did extensive research on adding mechanical to chemical prophylaxis. He found that there is no added benefit of mechanical over chemical prophylaxis.
Yes, I understood that, but that's different than the Russian experience, where patients who had a score of 11 and above, they were divided into 2 groups, getting low molecular weight heparin alone or low molecular weight heparin and sequential compression. There were 34 breakthroughs in the low molecular weight heparin group and 1 breakthrough in the combination of low molecular weight heparin and pneumatic compression. So that data that you're talking about, you have to divide the patients into very high risk, not all of the patients. Now, the other thing is that everybody forgets is what happens when you put a patient to sleep and give them a muscle relaxant. All muscle tone is lost in the legs. The veins dilate. Over time, the cracks can form in the endothelium. And with the venous stasis that forms there, you have all elements of Virchow's triad. Using pneumatic compression during surgery and the anesthesia is absolutely mandatory in order to prevent the Virchow triad factors from causing a blood clot. So that's another side of the mechanical compression story.
Thank you, Dr. Cabrini. We'll continue discussion, question, Dr. Ibrahim.
We are doing bariatric surgery to improve our health immediately. If we feel this patient is not well at the beginning of surgery, I will not this patient to smoke clinic and try my best to educate him the importance of stopping this problem before approaching and getting another one. Because if you actually I got the try to stop, we will be our so, but we have to take it seriously. We have to dig deeper. Actually, it has to consider the patient. This actually so the concept. We have the concept. If you don't stop talking like this, regarding this issue. And we combine the idea what does it mean? And one cigarette, one that 2 or 3 cigarettes. Which patient, if you smoke 1 cigarette, will be a problem, but another will not be another problem. Trying to talk scientific, they have to stop. So, at least 2 weeks. وهذا الشيء اللي بشير عليه وعشان نكسر المرضى على الفيو لما يجي يوقفوا التوجيه ويشتري ويتحمل المسؤوليه يبقى يحقق المقابل ما يقول طبعا فيمشي ويتوقع انه في شويه نجاح لكن اغلب المرضى اللي يقول انا ما اقدر اوقف احول على وهذا مو راجع من يعطي المريض انه لا خلاص نركز فقط على توتال اجينست بعدين احنا نموت بالمصارات لما هو يجي ضربها ايش ضربها في البروبلم تصير في او فيدنج فيوتشرز
regarding smoking, I think no matter how much you try to convince the patient of quitting smoking, it's not really possible. So what we do is just we scare them and we tell them what we counsel them, we tell them what to do, what will happen if they keep smoking. I don't really stop any patient. I just try to explain the procedure and the effects of smoking on the procedure itself, and then it's his decision whether he's smoking. And I think it works most of the time, at least for me. Now, I have a question for the panelists, for Dr. Cabrini and for the panelists. We're talking about thromboprophylaxis, and now there is an era here with surgeons. They go towards stopping bleeding or zero bleeding. Whether with changing the surgical practices like applying clips, probably suturing, over suturing, using suturing the stable line, or using reinforcement devices. And also there are trends towards shifting to tranexamic acid to stop bleeding now. So what are your comments in this regard, since we're talking about thromboprophylaxis here?
Any question? Dr. Cabrini, are with us? So there is 2 things now, the discussion about smoking cessation, pre-operative, 2 weeks, 4 weeks, and what is the way to guarantee that smoke cessation. And the second question, the current practice in some centers using tranexamic acid as preventive of bleeding in terms of using anticoagulant, prophylactic anticoagulant.
So, well, the first question is, as far as stopping smoking, actually, if a patient stops smoking several weeks prior to the surgery, they develop a reactive accumulation of mucus, and it's actually detrimental. It's actually better to just let them smoke up until the time of surgery. I know that sounds counterintuitive, but I think that if you stop smoking for several weeks, and I don't know how exactly the timeline of this, but somewhere in that period, there's an increase in mucus, and so what happens is the smoke suppresses the natural mucus secretions that keep the airways moist and keep cleansing the airways, and you stop all of that with the smoke. So when you stop smoking, then there's a hyperreaction to that, and there's an excessive amount of mucus and so forth. So I think it actually could increase respiratory complications, but that's purely off the top of my head. I don't have any data. I don't know any data to support that. Now, the second question, were you talking about tranexamic acid, or were you?
Tranexamic acid.
Tranexamic acid.
Tranexamic acid. Yeah.
Right. I don't. I know the orthopedists use that, and I know there's some controversy about whether or not it increases the incidence of venous thrombosis, but I don't think that has a role in bariatric surgery. I think that the latest question in bariatric surgery is, can you get away from low molecular weight heparin and go to one of the newer anticoagulants after the hospitalization? So that, I think, is a question that's worth pursuing, but not the other question.
We don't use it routinely. We don't give it ourselves. And we consult hematology, and we give it specifically the حالات البينوريجيا والسبوتينج اللي تيجي. لا bariatric surgery.
لا هو حقيقة I've attended a lecture.
and بنتكلم عن experience. احنا بنعطيه when we have patient need to continue anticoagulant and at the same time have heavy bleeding, and they have choice between stopping coagulation. And this is still high. فهنا بنصادف hematology, and this is in my practice. This is the area. This is the time that we give them both, right?
Yeah, and I've had a study done by a bariatric surgeon in UK. He was studying the use of bioabsorbable buttressing material, which is Singard, to prevent bleeding, and the cost effectiveness using tranexamic acid. Pre-operative half an hour and continue with 24 hours. So they found that the cost is less, it's caused less stabilized bleeding compared to using buttressing material.
See, Dr. Ali, your end point is intraoperative bleeding or immediately post-operative bleeding. أيوة بس هنا بنيجي على another end point that we were just talking, إنه spotting and other probably can be serious, but less serious initially. Bleeding complication. This is not, that does not occur in the first 2 or 3 days. So down the road.
أنا كومنت بس على الكلام اللي يقول فاضل. Tranexamic acid, we have to use it in our patients for those. We published a study. Comparing those patients receiving tranexamic acid and then the procedure, bariatric surgery, and 2 doses more. Comparing to control group, those don't receive any of these doses. And we find out that the bleeding rate was higher in those who are not receiving the tranexamic. So this is why we published the paper. We sent the abstract to our coming conference. I hope they will vaccinate, inshallah. So at that time we will discuss more about our protocol and and why we initiated this, and what are the main findings?
في نقطة شوية سوري إنك أنت عشان تاخذ يعني significant data you have to have a large group. إذا أنت نسبة bleeding عند average surgeons let's say which is probably 1%. Right? So if you want to randomize people to have meaningful reduction in the incidence rate, you have to have a sample size of 10,000 at least. So I feel that, and you can, if I have 1% incidence of bleeding, I can 1%. That probably is acceptable. Then عشان أشوف إنه أنا significantly have a reduction in the bleeding, I have to have a way larger sample size. Can I do 300, 500 straights?
أرسل اللي هو through reference regarding
just one comment regarding bleeding. We're assuming the bleeding is happening because we're giving the non-molecular heparin, or are we going to use tranexamic acid? I don't think the bleeding is happening because of the anticoagulation we're giving. It's happening in the staple line. Most of it is in the staple line. So a good surgical technique, making sure you have a high blood pressure intraoperatively, a systolic high blood pressure, choosing the right height of stapler to use, good surgical technique, buttressing, doing all of the other stuff that we spoke about, that will give you a better outcome rather than concentrating, to give a material to stop the bleeding. And let's look at the root cause of the problem. And I think that's what we should look into if we're talking about bleeding.
Okay,
Another 15 minutes?
yes, we will move just with our last speaker, Dr. Hassan Batayan, who will talk to us about the portal thrombosis after laparoscopic sleeve gastrectomy. What are the causes? And he will give us some case presentations for that. Dr. Hassan.
بسم الله الرحمن الرحيم. First, at the beginning, I want to who already had one of his patients with portal vein thrombosis right here. So majority I can say of you already encountered patients with portal vein thrombosis. What was the time when it was the patient came back? Less than 2 weeks or after 2 weeks?
14 days exactly.
14 days. Less than 2 weeks, 2 weeks.
Maybe
so. So most of those patients with the presentation of that.
On this
slide.
That's the common facts.
Only? Not all of them usually that they have. Why we think it is important? Because unfortunately we start to see it more frequent than the BE with DVT. Like, let me ask the other way around, the question of BE. How many of you already had a patient with BE? 1, 2. Those patients during the same admission before the discharge, or they went home and they came back? They went home and came back. They already went home, came back. So the same admission. Okay. DVT. Patient with DVT. 1 admission only. So even no one of us saw any patient with DVT that and they came back. But we start to see it more frequent. And nowadays, and since the starting of this problem of the DVT, so this is, I will give you just a conclusion of those 3 patients. The first patient, 38 years with the BMI of 48 and 2 weeks duration. The lab usually insignificant. The CT scan confirmed the diagnosis. And the patient was lucky, and we were lucky that started on anticoagulant. She went smooth, and we were happy, and she discharged again on anticoagulant. But the second case, this gentleman with a BMI of 47 and the labs and everything, the patient started again also conservative treatment, and everything went smooth. And again, he was shifted with anticoagulant and discharged home. This is the third case that I would like to discuss with you. This patient Unfortunately, his CT scan showed the portal vein thrombosis, but there was a finding regarding the small bowel, and that's usually what they wrote for you in the CT scan report, that thickening and bleeding, and the rest of the small bowel is still congested and so on. So such patient, would you be in a hurry to take him for OR for diagnostic laparoscopy or not? No. Like, who say no? Raise your hands, please.
Unless I know the radiologist very well.
Well, if you see the scan before mentioning that there is a thing is.
You mean your question has been that you will depend on the CT or you will go clinical?
Shukran. So the other things, then we want to depend on clinical plus the radiological finding.
It's clinical, it's not gonna show it the valve is dead. The patient won't be symptomatic, the valve is actually dead. You need certain amount of bowel to raise your lactic acid. So yes, if you have a high index of suspicion, go ahead, stick a scope. You're not losing anything.
That's very difficult. Very difficult to be able. So I think it's better not to wait and not to hurry and take the patient for surgery. So just wait and see the development of the clinical science and. Okay.
I would coagulate the patient, anticoagulate.
Yes.
Massive anticoagulation and
Yeah.
observe, see his progression. I have a case that presented post sleeve gastrectomy with portal vein thrombosis. 8 weeks post surgery. Patient was non-compliant. We gave him the take-home medication, as I call it, anticoagulator. He didn't take it. And he came with severe abdominal pain after 8 weeks, non-explained, anticoagulated and everything. He went home. He came back after 6 months, and it was equivocal whether to go in. He had abdominal distension, abdominal signs, CT scan finding. And we held our horses. He did all right, and he went home. He kept complaining for the next 6 months. Of every time he eats, whatever he eats, he gets severe cramps in his mid-gut. Okay? Came back after 6 months from this episode of complaining with acute abdomen, with perforation. And I presented that case sometime, and we had to do resection. He had an established portal vein. He had the venous drainage accessory system working with the anticoagulation, and he did all right. But he had a segmental ischemia of mid-jejunum, and that have led to bottleneck ischemia, and that rupture perforated at one stage, and the whole bowel came and tried to mend that, and it ended by resection, and small patient did very well.
For how long time did you wait until you?
I'm telling you, 9 months, 9 months until we got an acute abdomen, and we only intervened when the patient came to the hospital with the frank fluids in the abdomen, air in the abdomen, CT scan, obvious bowel perforation. And that was very difficult to identify because of the bowel clustering and the chronicity of the procedure, of the process. You know, when you have 9 months post-established portal vein, when you waited so long. So the question is, if I went in when he came with this situation, would I have made a diagnosis with laparoscopy? I doubt it.
You may make a diagnosis, but you will not do anything. So I don't think that you have.
No, diagnosis we made, I mean, would we have made a diagnosis for surgical intervention?
I mean,
Would we have made it, we haven't seen avascular changes or ischemia that would make me say, yes, I will go and resect this part? I don't know, I don't think so.
I think everybody went early, ended up resecting more than. Look, good number of patients ended up with short syndrome unnecessarily. You're delaying anticoagulation, and I think I don't want to spoil your presentation, but we've seen too many portal vein mesenteric occlusion from bariatric, non-bariatric. And the last one we just had like 3 days ago, sorry, a week ago, and we were fighting with somebody. I think the message here not to take long, but resist operating on these patients. They all have abdominal finding. They all have vocal acute abdomen. Saying the clinical findings, they all have pain. They all have tenderness. They all have some sort of rigidity. You give anticoagulation and you wait and you wait and you wait. Even if you need to do it properly. I'm not sure Dr. Bukhari's case is very much related. 9 months is you want to happen after 3 weeks. No, I mean duration wait is 9 months after 9 months. But anyway, and at any rate, I do not operate. And whatever I see this scan, I do not operate. Yes. And all of the patients will have some elevation of that, I guess.
The next question is that, are you going to repeat the CT scan? Who is going to repeat the CT scan? During the same admission, the patient always, as mentioned by Dr. Farid, I have pain, and they continue to have pain. Every time you come in the round, they say, still they cannot tolerate oral intake, still they have the abdominal pain. Are you going to repeat the CT scan? Who will repeat? If deteriorate, but if no deterioration, almost the same. You will repeat the CT.
I'll hope for another interview.
It's the same admission, let's say 2 to 3 days, that the patient still is not improving. Every time you come in the round and you still put your hand on the patient, still she is pain, and still she is not tolerating orally, and so on.
What would the CT give you as an information after 2 days that you wouldn't get clinically?
So the issue of the progression. Thank you. So still we should depend on the clinical judgment that to combine the examination and the physical examination with the CT scans for this one.
Not only, I think also biochemical changes that happens, that has to be together. They call it the triangular, the triangular spearhead, biochemical, CT, and
Clinical.
physical examination. And if they progress, I think, and you have progression of your biochemical enzymatic changes whatsoever, I think that's an indication for a repeat of CTs. Repeat.
I think if it's deteriorate, this indication to go for surgery, not to repeat, maybe to go for exploration. If he's stabilized.
But you build that not only in your.
Yeah, exactly, yeah, I agree.
On your.
You have to give time also.
2 to 3 days, if he deteriorate, then exploration surgery, not to repeat. But if he's improving, as the Dr. said, then we go to do just before discharging the patient, CT scan, and just to follow it up later on.
Like, when I reviewed the literature, strange enough that I found what is written there regarding the etiology is those things. Regard the predisposing factor is cirrhosis, infection, malignancy. And none of those is actually in our patients. So what do you think the etiology? Again, I review a lot in the literature. Dehydration. So this is again regard the systematic factors and also the other predisposing factor. Again, none of them except for some cases made with the oral contraceptive, but nothing also related. Again, I review more. We found some sort of regard gene mutation, and I don't know regard this also. It's an expensive investigation that will not be run for all patients, and you found because sometimes it's in very young, healthy patient that he has nothing apart from the obesity. So the possible etiology factor regard the venous spaces, the intra-abdominal pressure, the intraoperative manipulation, and sometimes the damage regard the lateral thermal injury from the ligature, from the harmonic or the device that you are using. But finally, I found that most of those patients is dehydration. And nowadays, since we are in the winter, we also see that risk more. My colleague, Dr. Al-Hassan Mulabi in Riyadh, also the same thing, they noticed that I think Khalid University Hospital in Riyadh, they have higher incidence in the winter rather than in the other timing of the year.
Again, you have to have good number to see season. You have two patients and one in the winter and two in the summer.
So that's conclude my.
Is male gender a risk from that? I noticed all the 3 patients you presented are male patients. So I don't know.
Unfortunately, for the last 2 weeks, our patients who are admitted females.
Actually, all my 4, and you can't tell, all my 4 portal vein thrombosis are smoker. So, see, we have different risk factors, but I think it's the surgical technique itself. We are working in the field of splenic artery and vein, or the splenic vein. I think this is the main issue here. Plus the other factor, dehydration, smoking, but I think it's surgical technique.
The pressure and the laparoscopic error, because even it happened for some other laparoscopic procedure. And I found some of these data regarding. Then the largest number is with the Roy gastric bypass, and even the upper abdomen. You see the niches and the plication, still they have those patient portal vein. So the laparoscopy itself, it's considered also a risk.
Yeah, that does not explain. And I think we published, I don't know that, but I think they published this sleep paper. Not there. You have to be I know we had initially we analyzed 500 patients and we find 4 portal vein. It was alarming. At that time, nobody was really talking much about portal vein thrombosis. We published this probably 6 years ago, and the data was another 3-4 years before. And surprisingly, our 4 patients, male, female, no risk factors. One of them I remember very well. She was probably one of the fastest procedure we ever had done, and the liver was stuck in the up, so we didn't even have to do the liver. So I think retrospectively, and we reviewed that all what you regarding this, and it seems particularly at that time there wasn't nothing much. Particularly now, sleep is known to cause more portal vein thrombosis. For example, in Mido, it's short procedure. My analysis, again, not evidence based. It is probably we're re-changing the portal flow, and it's something we do with the portal flow redirection that cause some kind of change, because there is no other explanation. We're doing too many longer upper GI surgeries, and we don't get this problem. We don't get this problem, except rarely. We don't usually see this. We do catastrophic if you see it in Peri-Operative, but we don't see it in Peri-Operative as much.
Maybe because it's the bigger number of people.
But you look at
but in the era of bypass,
for example, North American data, it was always the other way around. Sleep was not sleep was not relative. And their numbers for the root and why the European the standard procedure, why and they don't publish this. And you're right, locally, yes, maybe, but I don't think it's what international.
yes.
You're right. It's something to
Continuation for the sake of time.
It's okay. We can stop here. That's fine. No need for the rest of the slides. We can conclude لأنه مشكلة المطعم تحديدا في الساعة 11 وبشوية يرسلوا لنا. So
11 يا ابو خالد 5 دقائق ما بدينا ناكل فيها نكمل
The only thing and the problem is the early management and the solution. We face it really quite frequent that sometimes the patient comes to the ER, no high index of suspicion from the emergency physician, and just only know that that's a normal pain or so, etc. They will not request CT scan, and even sometimes we have 2 of the cases. They did the CT scan, but not with the proper delayed phase and protocol, so they would not detect it. And the patient went home, then come back again, then discovered that after it's repeated, that yes, it is there. So just to keep high index of suspicion, especially in those patients, early management with the anticoagulant as mentioned,
Hydration.
and good hydration. I think this would be the key. Thank you.
We'll give the talk for our moderator and chairperson at the end. Would like to thank you all. Dr. Kabrini is still with us?
Yes.
Yeah. Dr. Kabrini, you have a comment regarding discussion of portal vein thrombosis?
Well, I think it's a very complex thing, and the first issue from a surgeon's standpoint is you're working in the area of the splenic veins and that circulation, the portal circulation, so that is a definite risk factor. The other thing is that the number of risk factors that the patient has will also factor into the final result of whether or not the patient gets a portal vein thrombosis. Now, in my experience, if somebody develops a mesenteric or portal vein thrombosis, I treat them just like I would treat a DVT, and I have some special criteria. I think one of the problems is that they don't get treated adequately and for long enough. And in my experience, if I would have to have that patient with a portal venous thrombosis treated for at least 6 months, at the end of 6 months, a CT with infusion to make sure that that clot is gone, and also a D-dimer and a factor 8 and a ristocetin cofactor, which is part of the von Willebrand's factor. I do all 3 of those because if they're elevated, then the chances of recurrence are high, whereas if they're all normal, the chances of recurrence is low. And again, this is based on clinical experience. I can't quote a paper on this for mesenteric thrombosis, but until proven otherwise, a thrombosis is a thrombosis. That's my comment.
Professor Cabrini, it was a pleasure seeing you in person. This is Dr. Walid Bukhari from International Medical Center in Jeddah, Saudi Arabia. And
thank you.
Confirming the extension of the invitation for you to come and visit the beautiful Jeddah in our next meeting in February. It would give us a great honor to host you in the beautiful Saudi Arabia. Thank you very much for an interesting, beautiful talk. It was very interesting, intriguing. Thank you.
So I can tell you, I would like nothing more than to come over, but you know, in 2021 now, it's about 18 months, I suffered a major pulmonary embolus, and I have a bilateral May-Thurner syndrome, which means both iliac arteries are compressing my left iliac vein. I have no clots remaining. I have no clots in the legs and no clots in the lungs, but I'm on permanent long-term anticoagulation. To fly long distances would be a risk factor that 84 and a half years of age, I'm not willing to do. And I terribly miss the invitation. I have multiple invitations to the Middle East, and I'd love to go there, but I just can't really do that right now because of the extenuating circumstances. And I love the warmth and hospitality of all you people in that area. It's a beautiful thing to witness, and people from your area and how beautiful and warm, and I think that's so in general, is that there's only 2 kinds of people in this world, good people and bad people, and you're definitely good people, and it's a pleasure. And I'm available to you over the internet at any time. Thank you very much.
Thank you very much.
On behalf of Saudi Society, Saudi Society Bariatric Surgery, Prof. Aidel Qahtani, Dr. Hassan Batayan, the head of the club. Thank you very much for coming. Thank you for Dr. Walid Bukhari for chairing the session, Dr. Tariq Jaber, Dr. Sam Jamal. Thank you for all of you. Dr. Cabrini has been welcomed by, thanks by Dr. Bukhari. Thank you all for your coming today. It's very good start. return of the club with this start, it is a great achievement for us. Next meeting, inshallah, will be 24th of January. The topic will be GERD and bariatric surgery. طبعا حناخد البروف بخاري حيقدم لنا long videos about vision and GERD. So you're welcome and we'll send you the topic. Now dinner will be في مطعم السفينة تحت. حياكم الله جميعا.
شكرا لكم.
الله يقدر يا مرحبا. حياكم الله شرفتونا. Dr. Cabrini, thank you. Have a nice day.
Thank you. Thank you.
Happy holidays.
Thank you. Thank you. Happy holidays.